Welcome to the Glucose Never Lies podcast. I'm John Pemberton, a diabetes educator and researcher living with type 1 diabetes since 2008. I started the Glucose Never Lies website when my son tested positive for type 1 diabetes antibodies. In that moment, I realised I needed to build a resource strong enough to guide anyone who might care for him. At first, that meant writing clear, actionable management guides, but listening to Peter Attia's The Drive taught me something. Peter's conversations provide depth across nutrition, exercise, pharmacology, sleep, and much more. But I always find myself wondering, how does this information apply to people with type 1 diabetes? And this podcast is my attempt to fill that gap. I have access to the world's leading researchers and thought leaders in type 1 diabetes. That gives me a unique opportunity to combine lived experience, professional expertise, and cutting-edge science, and to share it all on here in conversation. But an important note, this podcast is for informational purposes only. These conversations share knowledge and experiences. They do not create a therapeutic relationship. So, let's get started. Welcome to the Glucose Never Lies podcast, and this week you will be glad to know we have Dr. Laurel Messer with us, who currently works for Tandem but has a very strong history of working with type 1 diabetes as a diabetes nurse, primarily at the beginning at the Barbara Davis Center. So first of all, welcome to the show.
Thank you so much, John. I'm very excited to be here. Hi, everybody.
But that's not the official introduction. My actual introduction, the first time I ever came across Dr. Messer was I went to ISPAD Science School. I want to say it was 2022. I can't fully remember. But there was just kind of coming out all shy, seeing what's going on. All of a sudden, this large as life character coming out. Hey guys, how's it going? Nice to see you at Science School. I was like, who is this person? I love that energy. I need to know who that is. And it was, little did I know, it was yourself at the time. So it's just interesting when you meet someone who's got kind of a good level of energy, you just pick that up pretty quickly. So that was my first memory of you anyway.
It's a little scary that I don't remember it, but in general, I get very hyped to see people learning about diabetes. So it's a very spot on analysis of where we met.
So great. So obviously today the main topic is going to be talking about skincare, because you have done an enormous amount of work in this area. And most importantly than that, you haven't just done the work, you've shared those insights on several different formats, whether that's publications, the Panther program, talks, all over the place. But generally that makes its ways to healthcare professionals, and sometimes not all the way to people who are going to really get the benefit using these people. And obviously that's the idea of this podcast. So before we get into that, I'd like people to really get to know you a little bit and find out a little bit about your history. Obviously I mentioned that you started your diabetes nursing career at the Barbara Davis Center, but could you just kind of give us a bit of a background, a bit of a walkthrough of your journey into this space?
Absolutely. It's interesting because I would call it a calling at this point. I don't know that I was born to do diabetes, but I've certainly grown into it where it's what I go to sleep thinking about, and then I wake up thinking about. So I think at this point, diabetes is a calling for me. But it started 20 years ago when I did a phone interview for a position with Peter Chase. If anyone knows that name, he wrote the original Pink Panther books. Peter Chase hired me over the phone, sight unseen, to say, I need you to run a research program for diabetes devices. We have these new things called CGMs, and they last for 3 days, and you have to download it in clinic. And it's this revolutionary technology. So I joined Peter's team 20 years ago, before real-time CGM was a thing. And I immersed myself in this diabetes technology world, watching it grow before my eyes, where I discovered alongside people at the time that glucose levels are much more variable than we ever thought. So it was a journey. And what I became passionate about, so not just as a researcher, but as a nurse, it was important to me that the things that we are learning are disseminated to the people who need it. It's not just academic conferences. It's not just papers, but it's really making sure people living with diabetes or a caregiver understand the science behind what we do and why. And so I think uniquely as a nurse, I went on to get my PhD in nursing, but ultimately it was to ask questions that were directly applicable to people's lives. I am way less interested in theories and chemical reactions and much more interested in, but what do we do to make life easier living with diabetes? So fast forward 20 years, I started the Panther program, which helps healthcare professionals and people with diabetes understand differences of devices as well as practical skincare tips. And then 3 years ago, I made the decision to join Tandem Diabetes Care. So full disclosure, I still practice at the Barbara Davis Center within, very clear boxes for conflict of interest reasons. So I still see patients. I still do skincare with literally every patient I see in clinic. I do a full skin assessment and review of how to best use diabetes devices. But ultimately, I joined Tandem because I wanted to be one step closer to what's being developed for people in the future living with diabetes. And the place to do that is to be deep inside industry, to be able to use my voice with what everyone with diabetes has taught me over 20 years to make sure we're making the best products. So that's my career trajectory in 2 minutes.
So it's a pretty good one. But yeah, I think a few things that kind of struck me there is something I'm personally very passionate about is making sure that the information that's happening now has a very fast pace to the people who are going to use it, the actual user, which is obviously, in this case, people with diabetes. And the second thing, obviously, I used to work for Medtronic. 2010 to maybe 2015. So I have an understanding of what it's like to be on the industry side, not quite in the vice president level that you are in medical affairs, but still I have an understanding of, ultimately the companies are there for, first of all, to really help people, but second of all, they have to make money. And the reason why they have to make money is they have to be good devices. And to have to be good devices, they have to be in touch with what people really want. And so actually have someone within there who really knows that from 20 years of deep, ingrained daily experience to bring that to a company and sort of bring that voice in, I think is really, really, really valuable and really important. So, well done for that.
Thank you. One of the first things I did when joining Tandem is I hired a nurse whose full-time job is to sit with product teams and help them think through, if you made this decision, here is how it will impact the average person with diabetes. Not the high-end user, not the low-end user, everybody, because when you have that breadth of experience in clinic, you can say, here are the ways I foresee that being useful, and here are the ways I foresee that being a barrier. And I think that's one of the most exciting things about being a clinician in a med tech company is to help them make good product decisions, because we can speak to the lived experience of people, who use these products every day.
Yeah, perfect. So we're definitely going to get into that. I mean, my plan is, I'm sure we'll go off on a few tangents because that's just the way these conversations happen. That's what makes it fun.
Yeah.
Is to really, I'll ask you questions and you can walk us through. I was really interested to do a full skin assessment. That to me was like, oh, I wonder what she does. Right. Okay. I'm going to ask that question. I'm going to ask you about that. And then we'll build in there kind of from your assessment, what you're seeing, and then what you're seeing, what's the reason for that? And then what's the reason for that? What's the solution? So maybe we'll go down that route, but it'd also be a real miss for me and the audience with having someone who knows the Tandem as closely as you do and have written some papers, which I'll talk a little bit about later, that changed our practice where I work, and really find out what's the current state of play with that technology and what are the sort of the key things. So we'll get to that in the second half, but I think a really good place to kick off that just kind of piqued my interest was when you said, oh, glad, people come in now and do a full skin assessment. And so what are you looking for? So, well, I mean, I'll lay the groundwork. First of all, people who I support, we look after 300 children and people. They're all at least wearing 2 different stick-on devices, it's an insulin pump or a CGM device, which means, especially the young kids, they have only got so much real estate on their body. And if they get a problem with the skin on some areas, they are going to have a serious issue, and especially if it's on the areas where you want for the best, accurate, most performance of the CGM, which is the arm, and then the fastest insulin delivery, which is either the abdomen or the arm. So if you've got problems there, you're going to be compromising CGM accuracy and insulin delivery, the 2 main things that are going to control glucose levels. So like when people think about skincare, I think that's a bit of a boring topic. It's one of the most important topics, because if you do not have good patent skin, your glucose control is going to suffer hugely. So talk me through your, someone walks in, I come in, or my son comes in, and you're thinking, right, let's just check his skin. What are you looking at? What are you looking for? What's your thought process?
Yeah. Well, my first thought process, you're going to laugh at. Since I primarily see children, young adults, some older adults, but when I walk in a clinic, I first have to think, how comfortable is this person going to be looking at my skin? Because every teenage boy, when I say drop your pants, they're like, ooh, and I have to sort of break the ice and say, I've seen every butt in the entire Barbara Davis Center. I'm not going to remember yours the minute you pull your pants up. And that helps sort of break the tension. And this is where nursing is such a cool background for skincare and diabetes, because we are trained relentlessly about primary prevention and about just going back to basics. This is how nursing founded, with Florence Nightingale saying patients need fresh air. I mean, shocker. So when I open up a conversation about a skin assessment in clinic, the first thing I'm doing, in addition to looking at sites, looking at skin, looking at sites that are not being used, so I can really see kind of contrast in skin, and really first tackle, what are you doing before you put the device on? And this is back to basic stuff, where it's like, wash with soap and water, make sure there's not oily film on the skin, and make sure it's clean. Why is this important? Because if you have oily skin, if you have dirt on the skin, it's not going to stick very well, which means you're going to want to then tack on all of these extra chemicals and wipes to try to make it stick better. But sometimes it's just a matter of having clean, dry skin. Dry being really important too, as we get into the weeds of using different wipes and tacks and ways to help improve adhesion or allow more of a barrier. One problem I very commonly see is people don't wait for these films to dry on the skin. So anytime you have moisture under an occlusive adhesive, you end up having a larger like chemical or mechanical reaction because the skin is irritated. It continues to be wet. It doesn't have an opportunity to dry. So it sounds silly, but I spend a lot of time talking about washing with soap and water and then making sure the skin is really dry. Like, get out of a steamy bathroom and make sure you're in a dry environment when you place these devices. So it's amazing how much time I spend with teenagers talking about soap, water, dry. And they're rolling their eyes. And at the same time, I'm like, when was the last time you did that? And then it's silent in the room.
Wait, is that just have a wash in general?
Yes, it might be. And I don't open that conversation, only sometimes. Anna Berg is an incredible researcher out of Sweden, who talks about, consider not using alcohol wipes. That's another way that you can really irritate the skin before you even get the device on. And so soap and water and dry is sufficient for the majority of these devices, even long-term CGM wear that can go up to 14, 15 days, and even infusion sets. The risk of infection is, of course, higher with infusion sets, but overall very low incidence. And so if you're trying to balance reducing reaction versus a hypothetical infection, for some people it might be worth skipping the alcohol, just soap and water, to reduce the probability of having a skin irritation related to that.
Yeah, it's interesting you say that, because in the UK we don't recommend using alcohol. It's not like first line, where obviously it is in the States. It's just interesting because obviously all the IFUs come across with alcohol, and the parents like, well,
that's right.
why are we not using that? So then we have to go through a conversation. And just a couple of things that just struck me there. I really like soap, water, dry. That's so easy to remember. It's just like as simple as that. But the full drying thing is important. And another thing that we really talk about is, although that even now I understand the companies are sending extra sticky bits with them, we always say, look, we want to use as minimal stuff as we possibly can. So we're going to try 2 or 3 sensors or 2 or 3 infusion sets without any extra bits, because the ideal is we don't need any extra, because the more stuff you put on, you don't know you've got different chemicals, you've got more skin being covered, you've kind of got loads of stuff. If you don't need it, then don't start with it. Only bring it in if you need it.
That is exactly what I do in my practice, where I say, we have tools. So if you're having issues, let us know. We have an arsenal of different things we can try, but let's start simple. And for that very reason, John, that you just said, every time you introduce some new wipe or barrier, you're introducing more chemicals and more of a possibility that, hey, if you didn't react to the primary adhesive, you might be reacting to the secondary barrier. So it complicates the story of what is irritating the skin, what is not irritating the skin.
Okay, so we've
So
got our lead up. We've sort of a nice little lead up. We've got
yeah,
soap, water, dry. If
yeah,
we can get
yeah,
away with it, we're not starting with extra
yes,
sticky bits. We're only introducing them if we've got a problem. So we've now got a lead up. Um, what's your sort of next discussion in
yeah,
terms of once you understand the preparation that they're doing, what's the
yeah.
sort of next bit?
So the next bit is site rotation. And this one also, I don't want to pick on teenage boys because I have two teenage boys myself, but what I very commonly see, and so think of your teenage years when someone is transitioning to doing things by themselves. We see this thing where mom used to be the one putting on infusion sets or dad or caregiver. Now the person is doing it themselves, the teenage boy. What the teenage boy is doing is spending as little time as possible figuring this out. So what I typically see is the same site being used over and over. When I say, do you rotate your sites? They're like, yes. And then I'm like, show me. And they're like, they'll show me their abdomen and they'll be like, here, 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 here. And with CGM, I honestly don't care. You don't have the skin, the lipodystrophy changes with CGM that you do with infusion sets. But I cannot tell you how many teenagers I see who just pick two spots, go back and forth with their infusion set. And what ends up happening is development of lipohypertrophy, which I will say, I do not think clinically is the biggest deal in the world. I know there are some studies that show impaired absorption in lipohypertrophy. Interestingly, there's also a study that shows slightly better absorption in lipohypertrophy. I actually don't care clinically. What I do care about is that teenage boy does not want two lumpy horns on their abdomen. And this is where you can really appeal to a young
So that's a
audience where you're
different
like,
type of 8-pack. You don't want that one. You don't want
yeah.
that 8-pack.
And that's very compelling to a teenager where they're like, no, I really don't. But it also helps me set the stage for, so therefore you need to rotate more, because what we want, ideally, we want a cure, number one. That is hands down what we want. If we don't get to that in the next 20, 30, 40 years, if you still need to use an insulin pump 20 years from now, I want you to have healthy skin, as you know, maximize your healthy skin all across your body. And one of the ways to do that is rotate and give that skin and underlying subcutaneous tissue some chance to heal in between infusion sets. So I appeal to their vanity to tell them to rotate, but ultimately what I'm trying to do is set them up for a lifetime of getting creative. Anywhere you can pinch skin, you can put an infusion set, and you'll notice that like the more you can rotate, the wider real estate, the more that skin is going to have time recovering in between infusion sets.
It's just standard human behavior. It's the path of least resistance. So your arm is kind of
Absolutely.
your arm is
And I
kind of
don't
here.
blame 'em
The
at
easiest
all.
place is
Yeah.
just there. It's just
Yeah,
there.
that's
If
right.
just to go there's a bit
Exactly
harder,
right.
to go there's a bit harder, or to go there's
Or
even
yes,
harder.
or to twist. If you're
Yeah.
twisting, it's all sorts of effort involved.
The path of least resistance. Yeah, males.
Yes.
Sorry, males, but yeah,
Yeah.
you're probably the worst for that, including
Yeah,
me.
it's not just the boys, but definitely it's easy to just get in a habit. So that's part of my intentional time with them is let's get them unstuck. Oh, that's a joke. Unstuck from using the same sites over
There we
and
go.
over.
Whilst we're on the sites, so obviously changing around sites is good. Making sure, as you said, from a CGM perspective, we don't have a problem with lipohypertrophy, but we potentially are going to have an issue with reuse of the skin, disrupting the top layer, etc. So obviously rotating around is good for that position as well. What's your typical discussion with regards to sort of accuracy of devices and fastest absorption of insulin? Have you got preferential sites? Have you got your standard discussion that you do for that? Because I know for a lot of people that I speak to with diabetes and healthcare professionals, kind of, oh, you can wear it on your bum, you can wear it on, your side of your leg, etc. Yeah, you can do, but that will change how fast insulin is absorbed, and it will change the accuracy of your CGM device. So if you're swapping back and forth all the time, sometimes you get a bit of variability that you're not expecting. Do you have any of those discussions, or is that just kind of way too nerdy for you?
Oh, it's not way too nerdy for me. I love those discussions. I will be honest, though, in general, I am much more honed in on making diabetes a livable marathon rather than perseverating on small differences. What I tend to do is say, if that's where you'll wear it, wear it. Because I'm more interested in making sure that we are setting up people to feel like this is something they can do. And if they want to wear it in places that, there's small studies here and there that show there might be variability in accuracy. I don't think it's enough to overcome the fact that if this is where a person is going to wear it, I would rather they wear it anywhere than not wear it at all. And I do think with the onset of automated insulin delivery, we can compensate for subtle changes in variability. And the MARVs, the current accuracy of CGMs, if it fluctuates 1%, over the course of time or where you're wearing it, it's still, in my opinion, I'm not representing anyone here but myself as a clinician, it's probably good enough. Because if you're willing to wear that device, we've won 95% of that battle. So I don't care if the MARD is slightly worse in a place. I don't care if the uptake of insulin is slightly mechanically different in different skin tissues. We have automated insulin delivery, which over time can smooth that out. I'm not convinced there's a long-term clinical argument to say that those things will dramatically change incidence of macrovascular complications when they're older.
So it's a little
clinical
bit like
opinion. I'm not representing anybody else there.
It's like the nutrition and diet wars. The best diet you can follow is the one that you can actually stick with. It's like
that's right. That's exactly right. That's a perfect dietary analogy. That's right.
Yeah. So that makes sense. So obviously, the only probably caveat to that is try to avoid putting the CGM somewhere you sleep heavily on for compression lows, isn't it? Like if that's an obvious thing, it's trying to stay away from that. So a question we always ask is, how do you sleep? And obviously, I roll about like a crocodile. Well, doesn't matter. But no, I always sleep on my right hand side. I'm like a little baby with stuck in my thumb. Okay, well, don't put it on your right arm or on your right backside because then you're going to have some problems.
That's right on. And John, I'll be honest, I don't always remember to ask that when I'm doing skin assessment. It's only later when I'm reviewing glucose levels where I'm like, ooh, you were sleeping on your sensor there, weren't you? So, hey, hot tip I just picked up from you. I'm going to make sure to ask more intentionally about sleeping pattern. Yeah. That's right.
Cool. So we've got preparation. We've now got rotation. What's next on your assessment list?
Yeah, it's removal. Because again, working with children and teenagers and young adults, this is not where they want to be spending their time. So when I ask, how do you remove your CGM, your infusion set, it's usually like, I don't know, I just rip it off. Okay. They almost always use the word rip it off, which I find hilarious because this is where we start to introduce problems. When you over time continue to rip off infusion sets, CGMs, you are ripping off a layer of skin underneath the adhesive. And this is, so part of my research at Robert Davis Center, I looked around and I'm like, well, someone has got to know skin better than the diabetes literature. And they do. You know who it is? It's wound care specialists, wound care nurses. So I actually went into wound care, like cracking out old textbooks from nursing school. I'm kind of downloading some of the best practices. And this is, again, like super basic information. But one of the things they talk about is they call it low and slow, where it's like you're kind of, you can stretch that adhesive a little bit and very slowly walk it backward. Hold the skin tight as you slowly kind of peel it backward on itself. The low and slow mechanics make it so that you are taking off less skin as you go. And the reason this is important, as I said before, once you start to break down that skin barrier, I know you're rotating back and forth, but the reality is there's going to be some more tape on that area within a week. Not always, but this is, if the skin doesn't really have time to recover mechanically in between infusion set changes or CGM changes, that kind of impaired skin is already setting yourself up for a reaction the next time an adhesive gets introduced to it. So whenever they say, I just rip it off, which is what I hear all the time, I start to talk about the low and slow. And I also talk about, this is where I want you to bring in your additional chemicals is not the right word, maybe additional components. So a very simple one is you can use oil. You can literally use any oil. I had a very sensitive girl who uses olive oil to help her. She just rubs it around the sides of infusion sets or CGMs to help peel off that skin. You get that oil to sort of soak in, and you can do that low and slow procedure. So this is where I am a fan of using oils, you can use detached type adhesive removers because you can wash them off the skin immediately. And that's where I'm like, don't skimp on this part. Whatever it takes to get the adhesive off very slowly and gently is going to long-term pay off with that skin patency, as you're saying, John. And then wash it off immediately, soap, water, dry. So it's just as important as putting it on as making sure you're taking it off without using the terms rip it off.
Yeah, well, I mean, 100%. It's one of the first conversations I'll have when we're talking. It's usually the dads. The dads are the worst of this. They're like, so who puts the things on and off? And like, dad goes up, okay, you just go like this, don't you? And like, well, it's a plaster, isn't it? I was like, no, it's not. Okay, so you got to think this exactly low and slow. And now on prescription in the UK from primary care, we can get adhesive removers. So it's just on every prescription that goes out. It's just like a standard practice. And that's such a low hanging fruit for a clinical team. It's just when the letter goes out to the primary care physician that they're starting this and you need to change the insulin, it's just like, also prescribe this. And then it's also on your education program that this has got to be on because, again, you've got to wear these things for a lifetime. You cannot be ripping a layer of skin off every 7, 3, 14 days and then expect it to recover without then opening up the opportunistic infections, opportunistic, dust in there, which can start to cause problems. So, yeah, I mean, low and slow, either oil or some kind of adhesive remover, so we get it off, we get it nice and clean. So obviously, if people follow these kind of, I just put down some notes for myself. On the prep, we're on soap, water, dry. Then on the rotation, we're obviously just kind of making sure we're changing where we're putting the positions of things. And on the remove, we're on low and slow. And then with that also comes some agent to support it coming off nice and easily. So if people follow those things, everything's going to be golden. But the reality is that's not going to happen all the time. We're going to end up with these situations where we have skin issues that are developing that become more than just taking the top layer off the skin. We get some either infections or we get some allergy reactions. What's kind of going on there? So I presume from what we've said, taking the first layer of skin off is something that is increasing the chances of these problems. But then obviously there are individual things that can cause issues, such as the particular type of chemicals within different adhesives bearing on different manufacturers, for example. And then presumably what people come across in their daily life with different bacterias and etc. in their environment, it just happens to get an opportunistic infection. So kind of walk us through a little bit about what you understand and know of those things.
Yeah. So, this is where it becomes a tangled web of cause and effect and, what is an immune response versus what is just like a mechanical, not, inflammatory response. If I broke this down, I would say the most common thing that we see with diabetes devices is like a contact irritation. This can happen from mechanical, just exposure and the ripping it off. It can be chemical because, these adhesives are not for the faint of. So you think about, it's not only having to stick to your skin, it's having to stick a device to the adhesive to stick on your skin. You think about like a patch pump where you have this outline of a patch that needs to hold this pod on it. And so there are industrial adhesives that are needed for diabetes devices. If it's even just holding the plastic parts onto a patch of skin of adhesive, sometimes the chemicals for that can soak through and get onto the skin, even if those chemicals were not intended to be directly into the skin layer. So we just have to think about, there are some creative but heavy duty glues that are involved in adhesion for diabetes devices. And we can talk about that a little bit if you're interested. But in general, the majority of device issues we see are probably in that contact irritation. And the important thing to know about that is it's not allergic. It's not a full-blown immune reaction. It's generally just more, put something on your skin that made your skin mad, and now we need to deal with it. And that's good news, because when we go down the route of like an allergic contact dermatitis, that's a true immunological reaction that persists. It doesn't go away. You can't make it better. And when I track the literature on incidence and prevalence of these issues, it seems like The allergic component is really only in about 1 to 5% of the reactions that we're seeing. And they're hallmarked by, you see these widespread body-wide reactions. It's intensely itchy. There's like vesicle formation, which are like, little bubbles with clear fluid. And the thing that really makes it clear is every single time you put on that diabetes device, you have a reaction. It can be a delayed reaction where the first, you could wear it for 1 to 6 months and everything seems fine. And then suddenly, every single time you put it on, you're having a reaction. Fortunately, as I said, those are less common than your just typical contact irritation, which can be treated. Like when you have contact irritation without an immune response, you have the ability to do things. And this is where we can talk about barrier layers. We can talk about adhesive supplements. We can talk about ways to protect skin. And it seems like that's the majority of reactions.
So that's really important to kind of for people with diabetes and also diabetes teams to understand the difference between the two, because as you're saying there, let's just pretend you can't get perfect numbers, but 95% of the time it's due to mechanical situations, which the three things we talked about before are going to minimize those so much because you've taken care of that skin. So that is for sure. 95% of the time you have a chance to really minimize it. And we're going to talk about if it happens, what we can do. But I guess this 1 to 5% of the time, like you said, you'll know the difference because it's every single time. It's an aggressive reaction. It's more than just in one place, and it's reproducible. And if that's the case, then you've got a different thing. You need to contact probably the dermatology team, find out what's going on, and then have a further investigation. But that's a small percentage of what's going to be happening. Whereas the other bit, which is really what I think this conversation is best placed to discuss, is, okay, we've already talked about the prevention, the rotation, the taking off. But if we get this because we haven't necessarily followed that, what are the steps that we can follow to minimize the impact of this mechanical irritation? You mentioned some of them with different films and layers. So what are your go-tos?
Yeah. And I will say it's mechanical, but it is also chemical. I'm just making the point that it's not an immuno response. It's just more of an inflammatory response. Yeah. So, the obvious first go-to is a barrier. And there's two ways to do barrier. There is the chemical way, which is like a barrier film. I don't know. We probably use different.
Yeah, we've got Cavalon over here. Cavalon's a typical one that we'll use.
Intact has some barrier in it. There are a variety. Again, you go to wound care websites, it's incredible what you can find there for barrier films. But that's the kind that it's a liquid, you paint it on, and then guess what, John? Make sure it dries. So even with your barriers, let's not introduce additional moisture. Let's make sure it dries. For some people, especially if they're trying to mitigate an allergic reaction, you can go a little more intense by doing a film layer, like a Tegaderm or IV3000 is one of the brands we have in the United States, where you can actually put a layer of protection between the skin and the native adhesive layer. It's a little trickier. We typically suggest cutting a hole for either the sensor or the infusion set to go through. So you're kind of gauging where to put that. But this is a way to truly introduce a bit more of a permanent barrier between the skin layer and the native adhesive. So those are kind of the two categories of barrier that I find useful. And John, I'd love to hear what you think as well.
Yeah, so we typically use, if people are having some issues, we'll start with Cavalon, which is like the paint on one as you described, or spray on, which obviously let it dry, and then you put your stuff on the top. But often, sometimes we find it's sometimes not enough as you describe, and sometimes use the Tegaderm or the IV3000. The other one, I don't know if you've come across before, but something that's gained some traction, certainly in the UK, is something called Compeed, which is basically a blister pack.
Yes.
So, and the nice thing about that is it's sticky on both sides. So what you can do is you cut the shape out of your CGM. Like if it's a Dexcom G6, it's a big oval. If it's a Dexcom G7, it's a small little round thing. And then what you do is you cut the hole where the introducer goes through, and then you actually stick it on before you fire it in. So then it's actually on the applicator before you pop it in. Yeah. So then you don't end up then having to try and aim it through this place. It's already on there. So you cut the template, and then you cut the hole. And a lot of people are finding some real value to that. The only thing I'll say with that to consider for people to go and do, number one, is it's obviously great if it works. And number two, the way I always think of things is, it's like with diabetes, anything. If it works, it works. It's great. But the thing to really be mindful of, especially with infusion sets and sometimes some of these CGMs with smaller filaments that are just kind of going a little bit, not as deep as some of the previous ones. I wear a tubed pump, and the worst thing for me in the night is I go to the toilet and it just falls on the floor. And every time it falls on the floor and that tubing yanks where the cannula set is, if you can think of the cannulas just below the surface, it pulls it up a little bit. But if it's in deep enough, then it's okay because it stays in place.
Right.
But if you're already elevated a couple of mils because you've got a compede on, you've got a risk then of that pulling it out of the actual skin surface. So it's just something to be mindful if you're going to put compede on, is you're going to be reducing the depth of how far either that sensor filament or that cannula goes in. So just be careful with when things get pulled and tugged. But there's a lot of people in the UK who are using that compede strategy and finding that particularly helpful.
So compede is a hydrocolloid, is that right?
Yes.
It's kind of puffy.
Yeah.
Those are some of the greatest skin products out there. They're so gentle on the skin. They also have this secondary benefit of being able to absorb moisture. And so when we think about some of the mechanical irritation that can happen from skin that's not perfectly dry, or God forbid you sweat during your daily life, those compedes and hydrocolloids in general can kind of help soak that up. But to your point, they are thicker than your average like Tegaderm or something like that. And this might be just a question for you. I find those to be used more often with CGM insertions that are going to be on the body for longer. I see less people using those for infusion sets because in general, I feel like because you're replacing the infusion set every 2 days and the on-body footprint is smaller, I typically don't see the need to have massive barrier underneath infusion sets, but maybe different in your practice.
No, I absolutely agree with that. I think the two things that you mentioned there are the key things. Number one, it's only on for 3 days in general, so you haven't got that issue. The second one, obviously, the surface area is not as big, and the bit that they're carrying on the top is very lightweight and not high profile. Yeah. Whereas CGMs, I know they're getting better, but typically the CGMs are higher profile, they're higher weight, they're on for longer. So
they're on for longer. Yep,
is a big thing. That's but infusion sets now make it to 7 days. Won't be long before they're on for 10 days. Yeah, so maybe that will become more of a thing as kind of things go on. But we'll see. But yeah, I think what's nice about the conversation, you've got a few different options. You've got barrier films to start with, then you've got the next level up, which is you kind of like your IV 3000 and your Tegaderm, and if that's still not working, you've got sort of like the compede or hydrocolloid as you just described. So you've got 3 different levels to go before you get to the point of there's nothing's working. There's usually a solution somewhere on the way.
Yeah, and I'll just throw out one other one, and this is maybe there's some science in here, but right now it kind of firmly lives in like the art or witchcraft section.
We love the science and art of diabetes on the glucose nevertheless. So give us the art.
Yeah, so I'm sure you've noticed this too. Many people open up the packaging for like their CGM or their infusion set, and they even sometimes remove the adhesive tape backing and then let it air out for a few hours. Some people do it overnight. They're religious in how they prepare this. But the idea is some of those chemical fumes that have been vacuum sealed into the device, the sterile packaging, when you open that up and give it a chance to breathe, you're minimizing some of the exposure of those chemicals on the skin. Again, I don't have any scientific backing about this, but I learned from people with diabetes, and they are telling me that this works. And so I will tell you that people with diabetes say this works. It can't hurt. It cannot hurt to give that a few minutes to breathe before putting it on your skin.
Yeah, I mean, I would say definitely from there. So as we know, just from a simple perspective, if you bite into an apple and you leave an apple on the top for 2 hours, it starts going brown, and that's because of oxidation. The oxygen that's in the area makes some reactions. So if you do the same thing with some of those chemicals that get oxidized and therefore become less harmful because they've had more exposure to oxygen before they're stuck on the skin, it's just the same type of thing, really. As far as I understand it. So that makes
you know the science more than I do. I love it.
I've just made an analogy from a brown apple to thing there, so I'm not sure that qualifies as science, but it'll do for now.
It'll do.
But yeah, so I think we've got some really nice strategies and practical tips there for all kind of situations. A couple of things I wanted to get your opinion on, actually. This is probably outside of the skincare bit, but from getting the most out of CGM. So when they go to put it on their arm, what they do is they put it on their arm, and rather than just being gentle, they ram it against the arm and they squash the inserter right against the muscle, and then they click the button and they go, and the person who's receiving it goes, "That really hurts." I'm not surprised. They just like stuck it through your arm. They like just didn't put it on gently whatsoever. But actually what we're finding is once you put it on and you just do a slight, especially with the Dextrom G6 rather than the others, because it's already on, the sticky bit's on. If you do a slight withdraw and pull it away, it actually pulls the subcutaneous tissue away from the muscle and opens up a bit more space and even reduces the risk still of hitting their muscle tissue. So especially for the really slim people, that just kind of putting it on a slight little withdrawal before you fire it means that you get a lot less disruption hitting. So they're just a couple of things that we use sometimes depending on what people experience. I don't know if you've got anything on top of that or challenges to that as well.
We see a lot of problems with people smashing it into the skin, exactly as you say. When I'm training someone first time on a pump, they're really like determined to get that thing really stuck, both infusion sets and CGMs. And I say, wait a minute, you're not smashing it into your skin, you're placing it on the skin. And I think sometimes, especially if it's a parent doing it, I sometimes get a similar response by just asking them to gently pinch up the skin, not a tight pinch, not a strong pinch, but kind of just lift that tissue up a little bit like a pillow. For that very reason, you're not going to smash it into muscle. It's going to just sit better in that subcutaneous tissue. So I think both methods, the slight pullback or slight pushing up of the skin, can achieve that same optimal outcome.
I think what I will say about the slight withdrawal, and I do like the lift up, is if you do it too much, it messes up the firing mechanism. So it has to be a gentle withdrawal, not like almost sucking it off the back of your arm. Don't do the same the other way.
I think that's the take home for this kind of subtle technique is be gentle. You're not pulling, you're not ripping, you're not smashing. You're gently placing it on the skin. Cool.
Gentle indeed. Brilliant. So we've covered the prep, the rotation, the removal, if we do have issues, what we can do to sort of manage those. And basically, I think we've covered pretty much everything on there that we need to do. So just to put a bow on this, essentially the Panther tool from skincare that you led on is available, and we'll put some links to that in the show notes. Absolutely. And I think we give that out to the children, young people and their families who we support, and just say, look, kind of on here, you've got pretty much all the bits that you've just described. You've got links to good options for extra sticky bits if needed, etc., etc. It's all there in a nice packaged way. Is there any other place you would point people towards, or would you say that's your main go-to?
Yeah, pantherprogram.org is definitely, and we do the same thing at Barbara Davis Center. We either print it out for them or make sure they have the link in their electronic notes. To me, that's the best resource. Also, I wrote it, so full disclosure, I'm very biased to the Panther program.
You're allowed to give yourself a big up. You're allowed to give yourself the big up on here. You did a great job.
Thank you. John, one thing I'm encouraged about, I was looking at the academic literature last night. I know that's not who we are speaking to today.
There'll be a few people on here. Don't worry about that. From the app clinical community.
Okay. Well, when I did a search for skincare and diabetes devices, a paper that I wrote with these practical solutions, which very much mirrors the Panther program, came up as the #1 hit with the most citations. And I'm not saying that to brag, because many of my papers that does not count as, but I say it that it has been cited frequently because endocrinologists care about practical tips. They want to know the immunology and the hypersensitivity, whatever, but really they want to be able to give solutions to people with diabetes. So I am encouraged that there are resources out there for doctors, for even primary care, nurses, educators, dietitians, but also if you want it kind of digested down in a very tangible source, that pantherprogram.org skincare is the place to go.
Yeah, I mean, we'll definitely put links in the show notes to both of those. So if you want the sort of
Awesome.
science behind it, we'll
Yeah,
link
we
to
can
that
grab that
paper.
link.
We'll get your H
Cool.
index some more up on that one, and then we'll also link to the how to, what to do, which most people, kind of when it comes down to it, they just want to know what to do. They don't want to know the science. They just want to know.
No.
It's number one, it's from a reputable source, which is very, very important, which we've
Yeah.
established that is going to be the case. And then number two, very clear, actionable things, which I know we use that, the Panther tool very, very much so. So well done for that. So I want to
That's
switch
awesome,
lanes
John.
now. So we've done skincare. We have done skincare full, and I'll put a full set of show notes, and then if anyone's got any further questions, we can cover those. But I think we've covered the basics there. But as I said at the beginning, I'd be amiss not to kind of delve into some of the Control IQ specifics with you, and maybe about what's to come in the future. And I'll kind of preface this to say that we use quite a bit of Control IQ where I work. We've got 300 kids on AID systems, or 295 out of 300 on AID system. I want to say maybe about a third are on Control IQ. There's one of the first ones I started using, and obviously my analogy with the Control IQ is Spider-Man. With great power comes great responsibility, which is to say, if you know what you're doing, with the Control IQ, as in from a healthcare professional or a person living with diabetes, out of all the AID systems, you can get the tightest level of control, because you can adjust the settings according to what you need. But on the other hand, coming with that means you need to know what you're doing. And I'll say for certain at the beginning, because clinicians, and also people with diabetes on standard pump therapy, it was always generally change the basal rates or change the correction factors without any understanding of what drives what. So you just do what you did before. And obviously we'll make a 10 to 20% change. And that's kind of where we're fixed in, because that's where the mindset is, which is never fast moving enough. And actually with the different technologies, you're moving the wrong needle. You're pressing the wrong lever. And the paper that you, I believe, was lead author on, which looked at essentially, I don't know how many thousand patients on Control IQ, but it was a lot. And essentially you looked at what was the main drivers of highest time in range, and importantly, not at the cost of increasing time below range hypoglycemia. And it came up pretty clear, it's the correction factor. It's the correction factor that drives the algorithm. So if you want to optimize people on a Control IQ, you need to get down with changing your mindset to adjusting the correction factor according to the patient, and also according to the time of day. And I've got a couple of things that I've got specific examples I want to give to you and sort of discuss with you, but just want to hand that over to you and tell us a little bit about how did that paper come about? Yeah. And tell us a little bit more about it, because I'm really interested in this, because for us, it was a watershed moment for about our use of Control IQ, and it really made a huge difference.
Yep. So when I came to Tandem, the first thing I did was corner all the clinicians and say, what is the number one rule I need to know when I work with Control IQ? Because coming to Tandem, I've been an expert in every system, including Control IQ, but I didn't know that one simple answer. And they didn't either. They said, you can change basals, you can change carb ratios, you can change correction factor. I'm like, yeah. But which one is most important? And that's exactly why I did this analysis with an engineer colleague at University of Virginia. And, the highlights of the paper show you get improvement in time and range by changing all of those. You can change basal rates, carb ratios, correction factor. However, you're also trading off a little bit more hypoglycemia, which is also okay overall if it's not dangerous or persistent. However, in predictive linear regression analysis, we found that you saw a big gain in time and range with a tighter correction factor without any sort of clinical impact on hypoglycemia. So what that tells us is correction factor is a unique lever in Control IQ that can maximize time and range without necessarily that increased risk of hypo. And here's why we didn't know that, John. And I was to speak for my own clinical practice. We change basal rates all the time and we change carb ratios, but almost no one looks at correction factor. And because the other systems, the automation is not dependent on correction factor, that, I don't think people think about it. We have other systems where we say lower target. And that's great. And it works in intensifying therapy. Control IQ does the exact same thing, sometimes better, but increasing basals and lowering that correction factor to be very strong is how you achieve that lower mean glycemia. And I will also say the best part, and John, this might be what you want to talk about, is you can change it by time of day, especially in children developmentally. They are crazy with their insulin sensitivity needs changing all day. And because we have a system where we can directly impact telling the system how sensitive the user is at that time, we can really customize to maximize time.
So since you've given yourself the big up, I'm going to give myself the big up on here. So this is what I always say to my colleagues where I work, and I'm sure they think I'm a knobhead for saying it, but I don't really care. I would say, if all our patients came to see me and there's another girl and there's another doctor in particular who really know control IQ particularly well, we would have 75%, 80% timing range across for the whole kids, because we really know, we understand time blocks, we understand adjusting correction factors on the control IQ, can really personalize it to a person's circadian rhythm. And obviously you can have different profiles, but that means you really need to know what you're doing and also need to have effective follow-up. And there's no way in the world that people are going to be that nerdy all the time. So there's kind of like the preface of that. But the reason why I say that, and this kind of comes in with the Spider-Man analogy, is, and especially some of the younger children that we've used this off-label for, the under fives have this wicked problem of from 5 p.m. to 10 p.m. They go from needing little insulin to all of a sudden, boom,
all
their
insulin.
cortisol kicks in. And it's not just a small increase. The increase is ridiculous. And the other systems just can't keep up. So what we have to do is we have to throw in fake carbs. We have to do all sorts of, but we still really struggle to manage it. But on a control IQ, we just kind of ramp the basal. We make the correction very strong. But importantly, at 10 p.m., we do the opposite. Right back down to minimal basal, really, really relaxed correction factor, because then they become super sensitive to anything around 2 a.m. So the problem with some of the other systems is it ramps up the insulin to try and catch up, but then it stays really elevated at the time you really don't want it. And then bang, you come down, you're kind of like, what is going on? What are we doing to do? So in those particular instances, when you've got those circadian rhythms that these systems in general are not cut out for, because they don't have the scaling of this intensification of insulin, that's something you're not limited to with a control IQ. So that's kind of one that I'll give you. And a second one I'll give you is the teenagers going out getting smashed. So one thing with, when I say smashed, I mean on alcohol. So when obviously we never had the problem before. So when people used to go out on pump therapy and injections, we'd just say, after you've had your night and you've had an amazing night and you smash, just make sure you have a load of carbs before bed, push the glucose high, and we're all good. Like, you might be high in the morning, but who cares? You'll be safe. The problem, you do that on these systems, you do that and the glucose level goes high and it shovels loads more insulin, and you are in trouble. You are in trouble, and we've seen it loads. Whereas if you're on a control IQ, you just set up a separate profile, drinking profile, totally relaxed basal rates, totally relaxed correction factors. There's no way it's going to over deliver. So I will say, having that level of personalization, when you're thinking about those young children, you're thinking about drinking, and also the kids who don't want to bolus, just make the correction factors ridiculously strong and let that do the work. And therefore you end up with really good timing range, and the other systems can't keep up with that because they're limited again by the scaling of how aggressive the systems go. So I think that's, for me, with a control IQ, this kind of idea with great power comes great responsibility. If you understand what you're doing, you've got a solution for everybody.
I'm going to put that as my email quote, kind of in my tagline, because that's my job in medical affairs. Is I need to make sure that, John, not just you know the secret to unlocking control IQ, but all of our HCPs do. Because I'll be honest, until now, I'm not sure Tandem has gotten that message out in a compelling way. So we're shouting it from the rooftops. And to your point too, correction factor is not what you would intuitively think about. So if we can all remember that takeaway from here, it really helps set apart how to maximize control IQ.
Yeah, no, 100%. And I think I'll link to some of the stuff we've done before on the glucose stabilizer. We've got the Spider-Man allergy and like focus on the correction factor, et cetera, et cetera. So we'll link to that so people have some ideas. So that kind of covers, you know, some of the insights of how to use control IQ best. What's coming then from Tandem? You're allowed to give us any kind of, I know the Mobi's on the kind of horizon, and there's various different things, and also integration with the Libre sensor, et cetera. So tell us a little bit about what's happening.
Okay, so the three things, especially for European audiences, Freestyle Libre 3 Plus is coming to work with the t:slim X2 insulin pump. It is a 15-day sensor. Interestingly, it shows data every 1 minute. So Control IQ automates every 5 minutes, but for a person who really wants to look at their CGM all the time, which I don't suggest in general, by the way, but that is something that is different with the Libre integration from Dexcom integration. So coming very soon. The two other things that have been cleared and will be rolling into market soon include the Control IQ Plus algorithm, which you talk about off-label being under age 6, John. It now will be labeled down to age 2 because we know Control IQ works exceptionally well in very young children, especially for all those reasons we just talked about with correction factor and the ability to change by time of day. And then there are some additional features like an extended bolus up to 8 hours while automation is running. And then my favorite one, which is a temporary basal rate, which can be set during automation. So the other thing that we do every single clinic visit is sick day management. And the question becomes, what do I do if I'm sick and I have this increased insulin resistance? This is the only system where you can program a temp basal rate to increase or decrease with the protection of automation still going. So we now have an absolute go-to mechanism for sick days where it's like, stay in Control IQ, absolutely, but we're going to set that baseline higher because your insulin needs to change.
I mean, not that I'm obsessed with getting smashed, but that temporary reduction would work would work great on the alcohol front as well.
Could.
Like it totally would without having another separate profile.
You're right.
Yeah, you've got to get that in there as well. I'm not sure that's the terminology from the VP of Medical Affairs, but you can borrow it from me if you want.
Getting smashed happens. It just happens. So we want to keep people safe when they do. And then, yes, as you mentioned, Tandem Mobi is coming any minute now as well. It is our tiniest, cutest pump in the whole world. It is, it holds 200 units. It's rechargeable and it is completely phone-based. So again, thinking about our teenagers who are on their phone all the time, but they don't want to necessarily dig their pump out. It's a really nice, subtle way to manage diabetes care. And what we're working on right now at Tandem is to convert it into a tubeless form factor as well. So same pump, Tandem Mobi will be the same pump, but we're developing a patch for it to sit on so that you can choose to wear it as a patch pump, as a tubeless pump as well. So our innovations are to try to minimize the impact of diabetes on everyday wear, discretion being a really important value for many people with diabetes, and continuing to offer algorithm enhancements to, give people the best choices for their lifestyles, for getting smashed, for being young, for having insulin sensitivity changes through the day.
Living life.
Living life. That's where Control IQ can shine. So I'm really honored to be part of the development process to bring new solutions for people with diabetes.
Well, I want to be respectful for your time, and first of all, say a huge thank you. So I'm going to run you through what I've learned today. So this is to help the listeners kind of summarize within their mind as well some of the things they can take away, and also help ChatGPT as I go through and stick my show notes into to work out what it needs to do. So when we're talking about skincare, we're essentially talking about people's real estate for potentially 30, 40 years with diabetes. We need to look after this because this is where the accuracy of our CGM and the insulin quality delivery going in, the two most important things for kind of looking after the person with diabetes health. We've got the prep phase. We've got soak, water, dry, which we discussed. We've got the rotate the sites, and then we've got remove. We've got low and slow, and then some sort of agents to help it come off.
Yes.
If we do run into mechanical issues, which would be most of the time, 95%, we're talking about looking after the skin. We're talking about barriers, barrier films, barrier sort of spreads, and then maybe a hydrocolloid if necessary. So that's kind of the skincare in a nutshell sorted. And then when we sort of moved on, we sort of said, okay, we've got the VP of Medical Affairs on, from one of the leading ARD systems. What we really need to focus on is understanding that the correction factor is the thing with having several different time blocks available to personalize how the algorithm works for the person. And the correction factor is something that really offers a unique advantage with the Control IQ for that, because it doesn't have a limitation on the scaling up. You're deciding that by the correction factor. And that, again, offers great opportunities, as we discussed, for children, younger people, when we get the Control IQ Plus, coming in when it's officially for children of 2 and above, but also for those opportunities, as we talked about, with the temporary basal for illness going up, for getting smashed, going down. And, kind of the ability, as I said, from a Spider-Man perspective, with great power comes great responsibility. And I actually think that some healthcare professional people with diabetes actually like that because they like to have some level of control. Like, well, let's hand
Sure.
all things over. I don't want to hand everything
Yeah.
over. And
Yeah.
especially if you've got the ability for those things. And obviously, then we talked about a few of the future developments that are coming in the future. The Freestyle Libre 3 Plus, which people are well aware of over here, very tiny and very accurate, effective sensor. And then the Mobi in its different forms in terms of the current form factor with the Mobi with a cannula on, and in the future, potentially just an all-in-one. So have I captured pretty much everything there?
You absolutely nailed it. That was a perfect summary. Well
Great.
done, John.
Well, I appreciate your time, and certainly maybe at some point in the future when sort of different things are released, I'll give you a shout again, and you can come and tell us about kind of what's been happening from the tandem space, or if there's anything else that's just kind of popped up. But yeah, I just want to say thank you for giving the time. I know your time is very valuable. You're doing some great work over at Tandem, and just, yeah, we appreciate you.
Thank you so much. This has been an honor.